The NCLEX tests your ability to keep a patient alive under pressure. When alarms are blaring, definitions won't save you. Clinical instincts will. Clinical prioritization follows a rigid sequence: airway, breathing, and circulation. This is the ABC hierarchy. Consider two patients. Patient A is wheezing with an oxygen saturation of 86%. Patient B is sitting up, alert, but reporting sharp, localized chest pain. Who is your priority? You go to patient A. Chest pain indicates a circulation issue, but wheezing points to a closing airway. A structural threat to oxygen intake kills faster than a stable heart rate. Applying the ABCs systematically ensures you treat the physiological threat that is most likely to cause immediate collapse. We start at the top with the airway. A structural emergency means oxygen cannot physically reach the lungs, like a fresh tracheostomy tube accidentally falling out on day one. To prevent suffocation during accidental decannulation, your bedside kit must include an obturator and 2 spare tubes, one matching the patient's current size and one a size smaller. In pediatric care, these narrow paths fail even faster. For a child with croup, where swelling causes a harsh barking cough, you administer cool, humidified air to reduce the inflammation. If a child presents with epiglottitis, drooling, and fighting for air, keep your hands away from their throat. A physical assessment with a tongue depressor can trigger immediate airway spasms. For infants with RSV bronchiolitis, mucus clogs the path. You clear the obstruction by suctioning and monitor the chest for retractions. When the structural path is blocked, oxygen cannot enter. Without a clear airway, all other interventions fail. If the airway is clear, the focus moves to breathing. We are no longer checking the tube. We are checking the mechanical movement of air. When suctioning an artificial airway, the procedure is strict. You pre-oxygenate the patient first, and you only apply suction pressure as you withdraw the catheter. These evidence-based standards require aseptic technique. You also limit suctioning to 15 seconds per pass. Exceeding this limit strips oxygen from the patient and increases the risk of pneumonia. If the lungs collapse due to trapped air or fluid, a chest tube with a water seal chamber restores negative pressure, allowing the lung to re-expand. Monitor the water seal. Rhythmic tidling proves the system is functioning. Continuous bubbles in this chamber indicate a leak that requires immediate troubleshooting. For preventative care, patients use incentive spirometry. These deep, controlled inhalations mechanically expand the alveoli and clear out fluid. Breathing interventions are about managing pressure and ensuring the patient can mechanically move air in and out of the lungs. We finish at the alveolar level. This is where chemical gas exchange occurs, pulling oxygen into the blood and exhaling carbon dioxide. Patient history dictates your target numbers. A healthy adult needs an oxygen saturation above 95%, but for a COPD patient, 88 to 92% is the safe, acceptable baseline. A COPD patient enters an acute emergency if coughing up blood or if their level of consciousness changes. Memorize these blood gas ranges: a pH of 7.35 to 7.45, a PaCO2 of 35 to 45, and a PaO2 of 80 to 100. If a patient hyperventilates and their pH spikes, they are in respiratory alkalosis. Coach them to breathe slowly. This forces the body to retain the carbon dioxide it needs to balance the acid. Following a patient's physiological baseline prevents the error of over-oxygenating a chronic lung patient and stopping their drive to breathe. Medications also impact this system. Opioids cause central respiratory depression, slowing the physical rate of breathing to a crawl. When administering narcotics, you must continuously monitor the respiratory rate and saturation. If the rate falls below 12, you intervene before the patient stops breathing. Patient education is the final safeguard. For an inhaler, teach the patient to shake the canister, use a spacer, and hold their breath for 10 seconds to ensure the drug reaches the lower airways. Success on the exam depends on this sequence. Stabilize the airway, monitor the breathing mechanics, and interpret the gas exchange. Safe nursing practice is built on identifying the single highest threat to a patient's life and acting on it immediately. Hey, thanks for watching my YouTube channel. Don't forget to like and subscribe and leave a comment. Let me know what topics you want to see more of and how I can help you become the super nurse you were born to be. I hope to see you here again real soon.